Great. Well, let's go ahead and get started. Thank you, everyone, for joining us for today's Doctors In program. Our topic this month is sexual health. Very happy to have you all joining us here on Zoom or on Facebook. My name is David Griffith. I'm the Director of Programs and Outreach for the Elder Initiative at the William Way Community Center. Doctors In is a partnership between us here at the Elder Initiative and the Jefferson Department of Family and Community Medicine and the Jefferson Center for Urban Health. So we're pleased to be able to offer these monthly health presentations with Jefferson geriatricians, palliative care professionals, and other healthcare providers sharing their wealth of information with us. And we are very pleased to have Dr. Michael Danielewicz with us this afternoon, who I'm very pleased to have involved in our Doctors In programming. This is his first Doctors In with us, but we actually have worked with him in some other capacities through the Elder Initiative and Jefferson before. In addition to being a geriatric fellow, he also has a great background in LGBTQ health. So we're very happy to have him with us. A couple quick housekeeping things before I turn it over to Michael. At any point throughout the program, you are welcome to share your questions with us, either through the chat or through the Q&A at the bottom of the Zoom toolbar. Do know that if you are putting anything in the chat, it does attach your name to it. If you have anything that you would rather ask anonymously, you can use the Q&A feature, and there is an option to ask your questions anonymously. So if you are more comfortable doing it that way, definitely feel free to use that Q&A feature. Anyone who's watching us on Facebook, feel free to put your questions and comments in as a comment to the Facebook video, and I will be checking those and can relay any questions back to Michael. So with that, very happy to turn it over to Dr. Danielewicz.
Thank you so much, David. Very excited to be here and talk about a topic that is really quite important. So like David mentioned, I'm going to be talking about sexual health today and all that that means for our LGBT older adults. As soon as my slides advance. So today we're going to cover a number of different topics. We're going to start with an overview of the sexual health of LGBTQ plus older adults, go into some of the safety things as far as STIs, risk factors, safer sex practices. But this is also a talk that's more than just about STIs, because I'm sure many people have seen talks that can really focus only on that. We want to focus today as well on how to make sex pleasurable, because it should be. What doctors and systems are trying to do to help with all of these things, as well as some local resources for sexual health that we can focus on and offer to you all today. I really want this to be as interactive as people want it to be. So I hope if anybody does want to put comments out there anonymously or with their name attached, feel free to do that and we'll stop at any point. So that said, I want to start with this idea of how individuals define sexual health. So I want you all to at least think about this. If not, actually put a comment out there. We'd appreciate it if you do, but if you don't want to, just think about what is your definition of sexual health? And also just think about how that might differ from how the medical system defines sexual health. So if anybody has any comments, we'll take those now, but if not, I just encourage you to kind of keep that in the back of your mind as we do the rest of this talk. So we'll certainly come back to that idea. I want to start with an overview. And the big question is, are LGBTQ older adults having sex? And the answer is yes. It seems kind of obvious to say that, but this isn't actually discussed as often as you might think in the healthcare setting or in society in general. And that really is not a good thing for a couple of reasons. One is that there's less education about sexually transmitted infections or STIs going out that is targeted toward older adults. And that means that there are fewer resources for workshops like this, just because we're not talking about it as much as we should be. LGBTQ plus older adults are at least as likely to be sexually active as those who are heterosexual. And those numbers are pretty significant. A good proportion of our population that is older is out there having sex. But like I said, physicians and medical professionals don't always address sexuality directly during visits with older adults in general. And why is that? There's a couple of possible reasons. One is that our medical system is kind of couched in heterosexism, which we'll come back to later, meaning the system trains people, brings people up to expect to be dealing with heterosexual individuals. The other is that despite the fact that medical professionals take care of a lot of older adults, there is an implicit ageism in our health system, meaning a lot of our treatments, a lot of our interventions, and a lot of our discussions are focused toward younger folks. So somebody might say, well, I guess that's not as important because, STIs, sexually transmitted infections, are not as big of a worry in our older adults, right? And that's wrong, actually. That is very, very wrong. Among folks who are ages 65 and older, studies have shown that gonorrhea, chlamydia, and syphilis numbers are going up and quite significantly. This population, so many of the folks who might be on this call or watching online, are uniquely at risk for all of these sexually transmitted infections. The cases are out there, and there is a quite big problem in that a larger proportion of older adults in general report not using condoms or other forms of sexual protection to protect against STIs. So what that means is not only are the cases going up, putting you all uniquely at risk, but people are less likely to use some of the safer sex practices, given some of the thoughts about older adults and aging, which we're going to get through here. Now, HIV in older adults is also an issue. HIV has tended to be more common in the LGBTQ plus community, especially among gay men and bisexual men. Now, that doesn't capture it fully, but the question is, why are we seeing more HIV in older adults? And there are really a couple of reasons for that. Sometimes it's people's first time getting tested. So they may have had an HIV infection for quite a while and just not known about it. There are those who are picking it up actively in the community now. And then, although this doesn't fully account for new diagnoses, people are living longer with HIV. Many people remember a time when HIV was not treated like a chronic illness like it is now, but people with HIV are now living full and long lives. So our numbers of people who are age 50 and older, the balance has tilted from HIV being predominantly a young person disease to now something that majority of cases out there now are in people ages 50 and older. New diagnoses, not quite as much, but it is still out there. So just something to think about. We're going to talk a lot about HIV prevention and just some safe practices around HIV as well. So that's the broad 90,000 foot view of this whole situation. I wanted to go through a review of basic sexually transmitted infections today. What this talk is not going to be, this is not going to be a talk with all kinds of horrifying photos of what could happen. That's not the goal here. This is not going to be a talk that goes into every little tiny detail in nauseating detail. What I think we need to do is go and look at this from a broad-based perspective and say, these are out here, here are the risks, and what do we do about them? There are a few photos, but I promise they are not super disturbing. The very basic stuff that we should cover first is bacteria versus viruses. Two things, well, many things can cause sexually transmitted infections, but our big category to start with is it a bacteria or is it a virus? Bacteria, which you can see here on the left, this is a beautiful color-enhanced photo of gonorrhea. And bacteria are caused by living organisms. So these are tiny microorganisms, and generally bacterial infections can be cured. Examples, gonorrhea, chlamydia, syphilis. It's getting a little bit more difficult to treat some of these days, but they can still be cured. Viruses, on the other hand, are in this weird in-between. I call them non-living. They have some features of life, some features that aren't life, but they are generally considered non-living organisms. They can't always be cured, with the exception of hepatitis C, which can in many cases, but they can be treated now more than ever. Some examples of viruses that you may have heard of: HIV, hepatitis, A, B, C, D, E, herpes, and human papillomavirus. We'll briefly touch on all of these as we go through this talk today. So the big question that a lot of patients come to me with back when I was seeing young people in the family medicine clinic, or even now when I'm seeing older adults at our Center for Healthy Aging, how do I know if I might have an STI? And the answer is you might or you might not know. Some infections do have certain symptoms. For instance, with gonorrhea and chlamydia, there might be penile or vaginal discharge, pain or swelling in the genital region. Syphilis kind of has this very specific sore that can come from the area of contact, whether it's in the genitals, on the mouth, or somewhere else in the skin. Later stages of syphilis, you may see a rash. With herpes, you're going to see small, painful blisters. Herpes is one that people generally do notice. Similar with HPV, you'll see warts. Even though they're not painful, people do get pretty bothered by them, by the presence. HIV is one that does not have necessarily a single ringing symptom. Some people, when they first get infected with HIV, may have fevers. Some people may have no symptoms at all. And that's the thing that I want to hammer home here, is that STIs can occur without any symptoms at all, which is why we need to be extra cautious. This is really the only photo of any STIs that I think is useful to show anyone, because visual inspection of partners is really important. On the left here, you will see these are warts caused by human papillomavirus. In the middle, you have what we call vesicles, or these little fluid-filled sacs that are found in herpes. And then at the right, this circular thing here is a marker of syphilis. It's called a chancre. And that mark, I do find that a lot of folks ignore this one here on the right because it doesn't hurt and it does go away on its own. We're going to talk about why it's important you don't do that as we move on. Now, again, I don't want this to be kind of a doom and gloom talk. I have good news, is that it's easier than ever to treat sexually transmitted infections. For bacteria, the treatments are usually antibiotics by mouth or by injection. HIV management has gotten better than ever. I put here that it's managed with medications by mouth. We're now coming out with long-acting injectable medications that really control HIV and make it a disease that people are living with and living full lives with. Herpes and hepatitis can both be managed and treated. Hep C can be cured. That's not necessarily true of all these viral infections. And genital warts can be treated with medications either directly on the skin to kind of chemically burn the lesions, or just freeze them off. Now, moving a little bit toward risk factors, I often have patients asking me, well, I don't think that I'm at risk for an STI. And the reality of it is, am I at risk? The answer is, if you are having any kind of sex with anyone, technically, yes. But these statements especially, and I encourage you all to think about this a little bit, can mean an increased risk. So there are 5 statements here. The first group is people who are having vaginal or anal intercourse with new partners over the past 6 months, 1 or more. The second, I have had more than one sexual partner in the last 5 years. This is especially true when we don't know the partners as well. People who have never been tested for HIV, especially those who have been sexually active for a long time, are theoretically at risk. People who use injection equipment, especially those who are sharing injection equipment, and those who use recreational drugs are at risk. And finally, people who are concerned that they might have an STI. People are often pretty good at predicting their own risk and noticing the symptoms even before we do in medicine. And this number 5 is really where I want to kind of bring home the point of, not every person who goes to a doctor is going to get asked about this. If this is something that you're worried about in particular, I highly recommend that we bring it up, because we are here to help, and that's the goal.
Mike, if I could interject with a question that came in through the Q&A, going back to the slide previous, I think. Do genital warts only appear on the genitals, or might those be showing up elsewhere on the body?
That is a great question. They tend to prefer that area because it is warm, moist, and there's a lot of skin contact. but technically the HPV that causes genital warts can appear in other areas. Now, I often get the question of, well, I have a wart on my finger, I have a wart on my toe or on my foot. Is that the same thing? And the answer is yes and no. HPV is a human papillomavirus. There are many, many different types of HPV. The ones that are on the hands and feet are not the same strains that cause the genital warts. Sorry, I went off a little bit there, but the answer is they can appear in other places. Thanks for that question. Now, as people age, the body changes. We all know this. Certain body changes can put older adults at higher risk of STIs. One of these changes is vaginal dryness. In addition to being unpleasant and affecting people's pleasure with sex, can also result in increased damage to the skin, damage to tissues around the vagina that make it more likely for an STI to make its way into the body. Similarly, but also completely different, erectile dysfunction, huge issue for older adults and adults in general, can make it a lot harder and less enjoyable to use condoms. So some people just don't use them, which again puts you at higher risk. Sorry, I have a technical issue here. There we go. So what I want to spend the majority of the rest of this talk talking about is making sex as safe as it can be and making it as enjoyable as it possibly can be, because that's the whole goal here. So some of this is very basic. Knowing a partner's background as far as STI testing can be really helpful. Encouraging partners who we're with regularly to get tested and getting tested ourselves is also really important. Now, some of these tests are blood tests, which I know is a barrier for some. Others are urine. When we're looking at the blood, we're really looking for things like HIV, the hepatitis viruses, and syphilis. There's unfortunately not any other great tests for any of those that don't involve blood. The urine testing is mostly for gonorrhea and chlamydia. Now, gonorrhea and chlamydia can also be tested through swabs if people have symptoms. Now, I don't think it's going to come as a surprise to anyone that protection is important. Skin barriers do prevent most STIs, not all necessarily, but this is the examples that I always give. Condoms, both the male and the female, because we use the gender normative terms here. The male condom is on the left, the female condom is on the right. Things like dental dams, also important. As I mentioned before, vaginal dryness or dryness in general during sex can be a big issue. So lubrication is important, no matter who we're having sex with, since small cuts can increase the likelihood of infection.
Had another question, Mike, that came in here, just about recommended frequency of testing for any of these STIs. And I know that may vary a bit depending on a number of factors, but are there sort of general recommendations for how frequently someone should be getting an HIV test or tested for other STIs?
So the guidelines from the CDC for HIV, the recommendations are yearly if you are in an at-risk group, meaning if you're having unprotected sex or having new partners or kind of fall into one of those categories that I mentioned earlier. Once it comes to things like gonorrhea and chlamydia and syphilis and the hepatitis viruses, that becomes much more individualized, meaning the recommendations, first of all, they stop at a certain age, which is unfortunate because they haven't caught up to the times. But second of all, it really is based on risk factors. If someone is coming to me and saying, well, I don't really use condoms, I have multiple different partners, my testing frequency for, say, gonorrhea, chlamydia would move to more of an every 3-month perspective, as opposed to once a year. Now, it's also different if somebody has been positive for one of these STIs in the past. So someone who has gonorrhea and I treat them, let's say if they have penile gonorrhea, I would want to retest them in 3 months. If somebody has gonorrhea in the throat, I would retest in 1 month to make sure we've cured it. So it really gets, I know it's not a satisfying answer, but it does get kind of specific to the person with testing. So then the question that I get all the time when I see patients is, well, I think I've been exposed. What if I have? If your partner has known gonorrhea or chlamydia, if you get that call a few days later and somebody says, well, I tested positive for gonorrhea, your doctor is generally going to test you. Yeah. It doesn't really change in many cases what we're going to do, which is if I know that my patient's partner has had gonorrhea, I'm going to go ahead and treat them for gonorrhea. It's better, in that case, better safe than sorry. It's not often that we like to throw antibiotics around, but in that case, especially if there was no protection used, there's a pretty high likelihood that that person is going to eventually develop gonorrhea as well. If the partner has untreated HIV, or if you don't know them as well, and you don't know that history and you get concerned, highly, highly, highly recommend seeing your doctor within 72 hours of exposure, ideally within the first day or so, especially if that exposure is from anal sex without protection. I didn't put that there, but that's important. We may be able to offer medication to prevent the development of HIV, especially if it's within that first 72 hours. Once you're outside that window, that option does not really exist anymore. So what we do in that case is we say, we will test for HIV as soon as we hear about this concern. That test doesn't necessarily mean anything right now, as long as it's negative, because the virus takes some time to grow, to replicate. What we then do is put the patient on 30 days of medication, 2 different medications, just in case they were exposed. And the data is really good that even if we were exposed and we start that therapy as soon as possible, we're able to prevent the majority of HIV infections during that time. What we then do is bring the patient back at the 30-day mark or slightly right around then and retest for HIV to make sure it's still negative. Which brings us to our next point about PrEP. PrEP is something that it's called pre-exposure prophylaxis. And what PrEP is really a once daily medication that's taken to prevent HIV. 2 medications are approved for this right now. They're very, very similar to each other, called Truvada and Descovy. And PrEP is something that when I was taking care of a lot younger patients, I had a lot of my patients on PrEP. I find that with older adults now, not as many people are just being offered it. And we'll talk about why that might be. But PrEP is very helpful for those who have either had a bacterial STI in the past 6 months, and especially for those who have had some kind of anal sex without a condom in the past 6 months. Now, this also holds true for people having sex toys that may not be cleaned, that may be reused between members of the pair during sex. Taken daily, PrEP can be very, very effective. The likelihood of prevention, the level of prevention rather for HIV is in the high 90%. So this is a very, very important medication. We'll talk a little bit about some of the cautions with using it in older folks, but I think it's still something that's on the table. And if you fall into one of these categories, would highly recommend talking to your doctor about it. So is PrEP right for me? You know, your doctor before they start it will want to check a few things. One, in order to start PrEP, you should not already have HIV. So your doctor will check you for HIV. The reason for that is that some of the components of these medications are used in the treatment of HIV. So we don't want to expose patients to that and let the virus develop resistance to that and then limit our options later. So they'll check for HIV. They will check your kidney function. Truvada in particular we use it cautiously in people who have kidney disease because it can have some effects on the kidneys. So we monitor that and we check a baseline. We also check cholesterol. Truvada is known to possibly affect the kidneys. Again, the odds of this are very, very low. I've never seen it clinically in my now going on 4 years of prescribing these meds. Descovy does not have that risk, but it can affect cholesterol a little bit. So if we're going to start somebody on Descovy, we would check cholesterol and make sure that that's okay, and then monitor it after a year. People who are signing up for PrEP also need to know that it is a bit of a commitment as far as visiting your doctor or provider. You need to have visits every 3 months, whether it's telemedicine or in person, kind of varies clinic to clinic. But we do need to make sure that we're doing routine HIV testing on patients who are on this medication, and checking in on the kidneys just to make sure. That said, PrEP, there are some risks, but in people who are high risk, I think the benefits in most cases outweigh those. So even if you may be older and maybe over the age of 65, we can say there are still patients that I have on PrEP who are at risk in their 70s and they're doing fine. Which brings us to the next question of, what if my partner has HIV and I don't? I've run into this quite a bit, especially with people who might have new partners, and they're worried about this. I want to give some reassurance here, cautious reassurance, saying there is really, really good evidence that when that partner with HIV is on medication and has what we call an undetectable viral load, meaning the virus is controlled, there is very nearly a zero risk of transmitting the virus. Multiple studies have shown this. So if your partner, or if you are on antiretroviral medication for HIV and you have an undetectable viral load, that risk is low, very, very, very low. I say that with caution because it's not true when the partner either is not on medication or has a detectable viral load. So for folks who partners we may not know as well, who we may not be sure if they're on medication, we can't necessarily be reassured unless we know a little bit more detail about, are they undetectable?
Did have a question come in, Mike, that is, I think, a little bit related to this one. For someone who is living with HIV, are there dangers of anal sex? And I guess that could be for them or for their partners.
Yeah, so that's exactly what I'm referring to here. As far as even with anal sex in people who are undetectable, the danger is thought to be very, very low. Some studies have actually showed zero. Some have that little blip. Now, that is in order to say that risk is so low, we would need somebody to be up to date and following with either their primary who's managing HIV or an infectious disease specialist who's going to be checking labs regularly. But yeah, generally the risk of anal sex, even without protection in patients who have an undetectable viral load, is very low.
There's actually another question that came in from right before the PrEP section. I wanted to let you get through this first. Are all lubricants safe for condom use? And are there certain types of lubricants that are more appropriate for different types of the male or female condoms?
It's a great question. And generally, the recommendation for condom use, especially for latex condoms, is a water-based lubricant is generally better for the condom integrity. The silicone ones, I've certainly had patients who prefer silicone lubrication, but they can actually across most types of condoms, latex, synthetic materials, and skin, it can cause some friction against the condom, which can either cause damage to the skin, which we don't want, or it can break down the condom a little bit in a way that makes it less protective. So if we're using lubricants with condoms, generally I recommend water-based lubricant.
Great, thanks, Mike.
Sure thing. One of the final things, vaccines are a big topic these days for protection against many things. That be my plug. If you haven't already gotten your COVID vaccine, get your COVID vaccine. But staying up to date on certain vaccines can also be really helpful for preventing STIs. Now, not everybody thinks about hepatitis A as being a sexually transmitted infection. In many talks, it wouldn't be included necessarily, but it is a fecal to oral, meaning mouth to anus, transmitted pathogen. And if sex is happening in that area, it is possible to spread hepatitis via sex. So because I use CDC guidelines here, which are a little bit behind the times on gender, but Hep A is recommended for any men having sex with men. The guidelines as far as our trans folks are not as clear necessarily, but I would recommend Hep A for my trans women too. Hep B is also recommended for the same group, as well as for anyone who is high risk, meaning in this case, having any kind of unprotected sex, in people who were born before 1991. Back in 1991, vaccination with Hep B, with the hepatitis B vaccine, became more common. Gotten asked a few times by my patients about, what about the HPV shot? Now, HPV used to be if you were under 27, then it went to under 45. Now, the CDC is not necessarily saying don't get it, but they have no recommendation for people over the age of 45 as far as HPV. Reasons for that are they just haven't studied it. It's not saying it's unsafe, they just haven't studied it, and the CDC doesn't consider the risk high enough to warrant study at this point. So if you are worried about HPV and if you are over the age of 45, theoretically, you can still get this vaccine. I would say your insurance is probably not going to cover it because it is not recommended. There is also going to be probably minimal harm, probably. I say that with the caveat that it has not really been studied. So the CDC essentially throws up its hands and says, we don't recommend that you get it. We don't recommend that you not get it. Make up your own mind. Most people will probably not get it and not think about it again. As with any of this, I am here to kind of offer general advice, but this does not apply to everyone all the time. If you have questions or concerns, talk to your doctor, talk to your primary care provider. And we'll show some resources later if you may not have one of those.
And another question, Mike, before we go on to the next section. And this, I apologize, I may have misinterpreted someone's prior question. On the question of the dangers of anal sex for individuals living with HIV, are other than transmission of the potential transmission of HIV, are there other health issues that you would be concerned about?
Yes, so there are a couple of things that are a little bit more concerning in folks with HIV. There is the risk of, and again, this risk depends on a couple of things. I'll start with that, actually. The risk depends on, is the virus controlled, and what is that person's CD4 count? If that person's CD4 count is nearing normal, meaning well over 200, well over 500, these risks become lower. Couple of things, repeat trauma to the rectum can theoretically increase the risk of rectal cancer. That is not something that is super well studied. It's thought to be a little bit higher risk in folks living with HIV. Similarly, there is this risk of rectal HPV, which can cause some of those what we call rectal dysplasia or rectal cancer. The guidelines currently on whether or not folks should be getting anal pap smears are not amazing for pretty much anyone except men who have HIV. So in folks who have HIV, I would definitely, and if you're having insertive rectal sex or bottoming, those are folks who should be talking to their doctor and getting some thoughts on having an anal pap smear.
Great, thanks, Mike. Loving all these questions, so thank you, folks. Keep the questions coming.
Participation makes this more useful for everyone.
Oh, and actually a follow-up on that, and how about for vaginal sex?
Now, for vaginal sex, for folks with, we're asking now about folks with HIV and vaginal sex. As far as increased danger, they're really, I can't think of anything aside from the if somebody's HIV is uncontrolled and they were to develop HPV as well, that could increase the risk of cervical cancer. But again, these are also in folks who do not necessarily have controlled HIV. So it'd be similar there as far as instead of thinking about slightly increasing the risk of rectal cancer, we're thinking more in the lines of cervical cancer. Mm-hmm.
Got it.
And that's, again, sorry, just another plug to just jump back, another plug for screening. Folks, I know nobody enjoys getting these screenings done, rectal paps, cervical paps, but that's, again, why we offer these things and why we think they're so important. So I think it's important with any talk to talk about infections and to talk about these concerns, but it's also important to talk about sex should be enjoyable. And we've already talked about some reasons why older adults may have some issues with this. So let's talk about some solutions that you all may want to bring up with your doctor. Erectile dysfunction, what that means is two things: trouble either getting an erection or maintaining one. It is more common with increasing age, but that does not mean that age alone causes erectile dysfunction. Erectile dysfunction may relate to medical problems, diabetes, high blood pressure. Sometimes it relates to some of the medications folks are on, and sometimes it can relate to some of the psychosocial aspects, meaning anxiety and depression. There are a ton of medications out there to help. I put the picture here of Cialis and Viagra. Cialis, Viagra, Levitra are kind of some of the more common oral medications folks take. And whether, Viagra is a little bit shorter acting, Cialis theoretically lasts a little bit longer. So these are medications work pretty well. There are a couple of different types of people who I would say, we need to be more careful with these medications. One is people who have heart disease or coronary artery disease and are on medications called nitrates. So nitroglycerin, those tabs that you put under your tongue, or some of the longer acting versions of that. If you are on those medications, I cannot say enough, please be upfront about that, and please do not take these medications. They cause blood pressure to drop very low in those patients, and that can be dangerous. Otherwise, there are, I am pretty open to prescribing these medications for my patients, including older adults. They work quite well. Now, what happens then when folks come back and say, it didn't work, I've increased the dosages, I've been talking to a therapist about my anxiety, and still nothing is working. First thing I do is look even before prescribing this, I look back in the patient's chart and see what medical problems they might have. If a person's diabetes is not very well controlled and their sugars are through the roof, that can certainly affect blood vessels and nerves that relate to erections. So that's something that we want to treat. Sometimes there are medication adjustments I can make that make it less likely to have erectile dysfunction. That said, some folks still don't get great luck with my treatments and they end up having to go see the urologists. And that's also a fine option. There are many other medications and even procedures that can help with erectile dysfunction. There are injections that can help and can last a long time. And there are also kind of the last resort that we look to are even implants, prosthetic implants that kind of people essentially pump up and can use for that. I get asked all the time this question about supplements and erectile dysfunction. I put a picture here of horny goatweed, which in addition to having a name that is very appropriate for what they're trying to sell it for, my short answer to this is save your money. Save your money, come see us. We can probably find things that are going to be more useful and in some cases less harmful. Evidence does not really support the use of things like horny goatweed, these testosterone boosting supplements, or male enhancement products. And some of them can actually be really dangerous. Horny goatweed, for instance, is not great to take if you're on any kind of blood thinning medications. So things like Coumadin, Eliquis, because horny goatweed can help thin the blood even more and cause a highly increased risk of bleeding. So I encourage you, when you go to see your doctor or your provider, be sure to either bring your supplements with you if you insist on taking them, or let them know what you're taking. But realistically, save your money. These are very expensive. I recently saw somebody who was on no less than 17 supplements and spending $200 a month, and we were able to pare down to almost nothing with no change in quality of life. So save your money is my advice. And if you don't want to save your money, at least bring it up to your provider. Nice X there. Vaginal dryness, in addition to being unpleasant, causing irritation, itching, and even pain with sex, may actually cause urinary issues as well, as the skin changes in that region, may make urinary infections more likely. We know pretty well that vaginal dryness is much more common after menopause as the hormones change. But fortunately, there are a lot of treatments available. Oftentimes, I find myself asking patients about this often, and sometimes people are hesitant to bring this up to their doctor. Either they think it's unavoidable, or they're embarrassed, or they just don't want to talk about it. So I try to be conscious and ask folks about this symptom. Treatments, they start with, in many cases, lubricants or moisturizers. Some of them are over the counter. Sometimes we can prescribe them. Estrogen cream is really useful locally. So it adds back some of the hormones that maybe the body is lacking now after menopause. Some people don't like the feeling of putting a cream in the vagina. So there are also hormonal vaginal rings. They actually look similar to the NuvaRing, the birth control ring. In some cases, they are the same, that are placed into the vagina, sit there. They're very soft. Most people who use these say, I don't notice it after a while. And they sit there for a certain amount of time and help to regenerate the tissue, essentially. The bottom line of all of this is that you deserve to enjoy sex, if you so choose. Bring your concerns to your doctor or primary care provider, and we are happy to talk about this with you. So going off that, I want to start wrapping up by saying, what are we in medicine doing to help here? You know, evidence is unfortunately pretty strong that LGBTQ plus older adults don't necessarily feel as comfortable coming and being their authentic selves with their doctor, that they may fear discrimination or stigma. And I want you to know that we really are trying to change that. We are trying to provide, it's very easy for us to say we're trying to provide the same level of care, which we are, but it's also important to say that we are cognizant of some unique issues and that we are cognizant of some of the history and the intersectionality of the community that we're working with. So the world is becoming more aware of the need for both medically and culturally competent care for LGBTQ plus older adults. Part of this does involve being comfortable with talking about sexual health and sexuality. Obviously, as David mentioned earlier, my interest is the care of LGBTQ plus older adults, so I am interested in this, but my colleagues as well, we're all learning more about this. And the very, very basic thing that we're doing is even changing the language that we use to be more inclusive. Instead of saying, are you married, using, are you in a relationship? Do you have children? Who is your support system? These are easy, easy changes that take some time because we've been trained in a different way. But these are changes that we can make and that we're actively doing. And there are a number of us out here that are also really interested in caring for you all and in helping you live your best lives. So I'm not trying to put in too much of a plug for the Jefferson Center for Healthy Aging, but I have to mention some of the efforts that we're doing at our practice to make it a medical home for LGBTQ plus older adults. I feel like I sound like an advertisement. I apologize for that. What we have already done is this idea of cultural competency or cultural humility, learning appropriate terminology, learning how to have discussions with folks in a ways that makes them feel comfortable. So we've done this SAGE training, which is Service and Advocacy for GLBT Elders. That training we have done it, all of our providers and all of our staff have done it. What we're now working on is creating a half-day workshop for our providers that myself and a few others are going to be leading on increasing knowledge of relevant issues, increasing knowledge of HIV medicine, of gender-affirming care, of screenings that are important, and of dealing with issues that may come up toward the end of life. And finally, we're looking at expanding our partnerships with the Elder Initiative. I think some of you may have participated in one of my colleagues' initial surveys last year. We're looking to do some focus groups this year. So we certainly want your involvement, whether or not you're a patient with the Center for Healthy Aging, because we want to know what you want in a practice. So I'm going to close by talking about some community resources here. Obviously, for STI testing, we are very lucky in this city to have some really fantastic organizations working with our LGBTQ plus folks. Mazzoni Center, both down on Bainbridge Street and at their Wash West project, do offer STI testing, often walk-in, fully confidential, of course. Philadelphia Fight, if you prefer a little bit of a different side of the city, you are welcome to reach out to Philly Fight. They also do a lot of STI testing. Planned Parenthood as well does offer that. Of course, your primary care provider. I think primary care is super, super important, especially as we age. Again, my final plug for the Center for Healthy Aging. If you do need a primary care provider and you're kind of looking for folks who are interested in taking care of LGBTQ plus older adults, we're available. Our number is here, but we fully respect wherever you decide to go. What's important is that you have someone and that you know that we're here for you. A few extra websites, just if you want any more information. SAGE, Services and Advocacy for GLBT Older Adults, is really helpful. Some sites for HIV and aging. And my favorite website that I found recently, Age is Not a Condom. And the whole idea behind the name there is that age alone is not going to be a protective factor from infection and from other sexual issues. So we certainly, a couple of websites for you all. I'm happy to take any final questions anyone has, but thanks for coming today and engaging. It's always more fun when people ask questions, and hopefully we've addressed your needs. And if there's anything else, my name is on the front slide. My email is firstname.lastname@jefferson.edu.
Awesome. Thank you, Michael. We'll give a couple minutes here if anyone wants to put their questions either in the chat or the Q&A. I will say I like that website, The Age is Not a Condom. We've pulled some resources from there. They have a lot of great stuff up there. So I would make a suggestion for that one too. One of the questions that I wanted to bring up, because I always like seeing sort of the common themes that come up in many of these doctors in presentations. But I think when we did one on medication a while ago, talked about how a lot of medications that people might be prescribed for various age-related health issues sometimes have the side effects of erectile dysfunction, vaginal dryness. Do you have anything to say sort of on that if someone is getting prescribed a new medication, kind of weighing the cost benefit, I guess, of potential side effects that could impact sex and sexual health?
Absolutely. In some cases, the medications, like I'll give the example of people often complain about their beta blockers, their metoprolol causing this. And in some cases, beta blockers are essential. If you have heart disease, that's kind of a medication that we really want people to be on, improves a lot of different aspects of care. Sometimes we can look into alternative. Now I'm jumping back from beta blockers and going back in broadly. Sometimes there are alternative medications that we can use. Sometimes we can augment with some medications like Viagra, Cialis, or if we're having vaginal dryness, prescribe some estrogen. But what I think is really important is that people need to bring those concerns to us, because I'm sure there are a lot of folks out there who are having these symptoms and just aren't bringing them up with their doctor, either because they don't think it's important, they don't think there's anything to be done about it. The most important thing whenever you're having side effects from medications is bring it up with us. And if you're not getting the answer, no one should feel like that's being just blown off and saying, oh, well, your heart is more important. Yes, your heart is important. I get that. Trust me, I'm not encouraging you to stop taking your medications. Don't read it into it that way. But what is important is that you're feeling heard and that we're actually working with you on this, because there are alternatives and there are things we can do.
Great. And I appreciate that you sort of included content in here on the importance of pleasure, that we're not just talking about, the risk of STIs, but that also pleasure is an important part of sexual health and wellness. And so sort of to that end, there was a question that just came in on any recommendations for experiencing pleasure or increasing pleasure during masturbation, either with or without sex toys.
Yeah. And that is a tough question as far as from the medical perspective, because every single person is going to have different things that kind of enhance their pleasure. Experimentation is often recommended, trying new things, trying different things, making sure that your health status is as optimal as it can be. So I know that sounds like a weird recommendation for somebody who's asking about pleasurable sex, but if you haven't been to a doctor in 5 years and you go and find that your blood pressure is through the roof and you have uncontrolled diabetes, those things are also going to affect pleasure as far as nerves and function. So it's hard for me to kind of say specific, like with or without toys, because everyone's going to be different there. But certainly once you get to a place with one of your providers who you feel comfortable with, discussing what works, what doesn't, keeping a diary of that can be helpful too. Writing things down is incredibly important in medicine in so many ways. So I know that may sound like a weird recommendation, but kind of keep a log of what is pleasurable and what isn't, and trying new things.
Mm-hmm. That's great. One other question I had, because you mentioned many times kind of the importance of bringing things up with your healthcare provider, how there is sort of still this stigma around STIs and around sex in general, and the ageism that comes up sometimes in healthcare settings. Your best advice for someone who might have some of these questions but feel nervous about bringing them up with their provider, whether it's around a potential STI or ED or vaginal dryness, kind of best tips for how to broach those subjects if a doctor is not asking about it.
No, absolutely. I'm a big proponent, like I just said, of really writing things down, kind of coming in with your doctor. You're going to come in and your doctor or provider has an agenda that hopefully aligns with yours. Sometimes I'm a little bit more worried about your blood pressure or your diabetes, but we really need to hear your agenda too. So I encourage you to advocate for yourself if you feel like the encounter is just kind of moving in our direction only. And that's hard. I admit that. But I would say starting it with even saying something like, "Hey doc, I have a couple of concerns that I'd like to bring up today." And this can be easier or harder depending on how much your provider knows about you, as far as, do they know that you are a member of the LGBTQ plus community? Some people don't even feel comfortable saying that. I encourage people to kind of think about approaching this in a way that makes sense to them. I'm a proponent of revealing as much as you want to reveal to your doc or to your provider, but certainly kind of making sure that when your doctor says, do you have any questions? Yes, I do. And here are some of the things I've been thinking about. And if you have it kind of written down, I find that it helps people stay on track and not realize as soon as the doc leaves the room, oh, geez, I had to think about this.
Great, thank you. Looks like that is all the questions that have come in. But so thank you so much to Dr. Mike Danielewicz for sharing all this information with us today, these resources, taking all these questions. Thanks to all of you who are watching, especially for these great questions. And I guess I would just leave it with you, Mike, if you want to share any parting words.
No, thank you. I mean, thank you so much. The fact that you're here today is really great. I always love the discussion. And if anybody, I encourage you to bring this up to bring these issues up with someone you care about or with one of your providers. This is our goal. Our goal is to help you not just live longer, but also live happier and live better.